I wanted to apologize. We didn't have our meeting a week ago. There was something going on. I don't know, Christmas or New Year, but we skipped that seminar. But today we have really truly a friend and one of the most intelligent person I met in my life, Andrew. Thank you so much for joining us, and I will pass it to John Hong, who possibly will tell you more about our speaker today.
Okay, thank you. It is my pleasure to introduce Dr. Andrew Dick. He is Duke Elder Professor of Ophthalmology and the Director of the Institute of Ophthalmology at University College London. He is a Professor of Ophthalmology at University of Bristol. He also serves as the Faculty and Theme Lead for Inflammation and Immunotherapeutics of National Health Institute for Research Biomedical Research Center at the Moorfields Eye Hospital and UCL Institute of Ophthalmology. Professor Andrew Dick studied medicine and biochemistry at the University of London. During his medical training, he did biochemistry research as a medical research council-sponsored research associate at Yale with Professor Coleman. He did lectureship with Professor John Forrester in Aberdeen, Scotland, to further his science training, and got a postdoctoral traveling fellowship to work with John Sedgwick at the Centenary Institute of Cancer Medicine and Cell Biology in Sydney, Australia. He did his residency in ophthalmology, and his clinical and research expertise is in inflammatory disorders of the eye. Professor Andrew Dick became a fellow of the Academy of Medical Science in 2007 for his significant contributions to research and scholarship in medicine. He was also awarded the Alcon Research Institute Research Award in 2011. He has previously been editor of British Journal of Ophthalmology, president of European Vision and Eye Research, master of Oxford Ophthalmological Congress, and also vice president of ARVO. Professor Dick has written 2 textbooks, one of which is a bestseller in ophthalmology and well studied by many students, and over 200 peer-reviewed publications. So without further ado, we graciously welcome today Dr. Andrew Dick.
Well, thank you very much indeed. Now, I've been enlightened and enthralled and envigored by Chris's musical taste, for which I thank him a lot. But mostly I thank you all for coming to listen and your attention. And I'm going to share my screen, and please let me know that it's working fine. Can you all see that now?
Perfect.
Yes.
Thank you. Thank you so much. So thank you for the very, very kind introduction. So as a clinician scientist, I did actually also do my internship in medicine, internal medicine first as well. And therefore I've always had an interest in the basic science and the immune processes aligned to inflammatory disease. And that sort of transferred through into understanding what goes on in the eye when I became an ophthalmologist, and continued that journey over the last sort of 3 decades. And I would like to take you through a story today, some of which is old data, it's clinical, some clinical data, some basic science data, and certainly some unpublished data, but mainly also giving some views regarding where I think we're going in this field, which is essentially generating a molecular and cellular phenotype of taxonomy, so we can actually do more precision medicine for our immune-mediated ocular disorders, which would include uveitis, but indeed also anything that is immune-mediated, which would include inflammatory diseases, and one could argue that would include macular degeneration. So hence the title, Endophenotype and Precision Medicine. And I'm trying to work out how to, sorry. So this is the conundrum, starting on the clinical interface. when you look at patients, you could do the traditional ophthalmological view, which is to precisely phenotype them by what you see. It tells us very little about what's happening mechanistically, and it tells us very little about any of the cellular or molecular mechanisms underlying it. And more so, while some diseases can distinctly fit into a phenotype, there are many diseases overlap, and many diseases in the ocular inflammatory field actually have multiple causality in the sense of they are aligned with systemic disease. So it becomes a conundrum that when we treat these patients, we have actually to date really very little precision about what to target and how best to target for an individual patient. And as a result, the morbidity of this disease, whilst an orphan disease, remains very high. The sight loss remains quite prominent, and also the morbidity of our treatments, because we blanketly treat patients, is frankly unacceptable. Or maybe I'm just getting to a stage in the career where I feel it's just unacceptable going forward. So during this talk, I'm going to be really reaching out to all my main collaborators I'll be talking about during this talk. And that they're listed here. I'll be talking and working with Dave Copeland for many years about his work. Lindsay Nicholson is a close collaborator within my department in Bristol. Richard Lee was a young PhD student, now an independent researcher of mine. And Colin Chu likewise, who's currently at the NIH working with Ron Germain. Ollie Bell, I'd like to just acknowledge, he's just got his PhD, and I'll be talking a little bit about his work on the tissue. And then three close collaborators, Jonathan Sherlock from Oxford, who's now with Janssen, and he's a rheumatologist who's been working, and we're talking about some of the work related to uveitis. And then my compatriot for pediatric uveitis, Professor Ramanan. And then I'll be really plagiarizing Jesse's work, who he's done with Colin, about how we look forward to immune imaging in the eye using adaptive optics at the end. So that's just sort of a start. So when we first thought about this 3 decades ago, we were really looking at generally in inflammatory diseases about extrapolating from the mouse model and putting it into man, and looking at uveitis as a sort of archetypal ocular inflammatory disease that allows us to sort of define some molecular and cellular mechanisms. By doing so, lumping it, as we didn't understand the etiology, into common effector responses. And what I mean by that is that we recognized from the animal model that this was driven largely by the immune compartment of the CD4 T cells, principally Th1 and Th17 cells, so canonically gamma and IL-17 driven diseases. And you can show that very eloquently in animal model systems and genetic modified mice to show that that's very true. But without the innate immune system, and particularly monocytes, macrophages, and neutrophils, you don't actually get the tissue destruction we've seen. Now, the problem with that is that we would have to align to say, is that really the same for all our diseases? So now we understand that within the umbrella term of uveitis, which simply just means an inflammation inside the eye, we can categorize and define that into certain ways. Do we have examples of classical autoimmune diseases where we lose tolerance to self-antigen, and this drives a T cell response against that antigen to deliver tissue damage? And the answer to that is not really. There's some good evidence that maybe in sympathetic ophthalmia, a very rare disease, and Voigt-Koyanagi-Harada, a little bit more common in our Asian communities, that this may be related to tyrosine-related proteins and T cell responses against those. And that certainly would acknowledge that more as an archetypal autoimmune disease. But most of the diseases we look at in uveitis are indeed either not organ specific and they're systemic, and they also don't really ascribe to a classical antibody or T cell driven autoimmune response. And therefore this term of autoinflammation, which has been around for a long time now, is originally coined due to polymorphisms in the innate genes that drive hypersecretion of cytokines, but now related to likely infection in the past induced dysregulation of the innate system that drives hypercytokine responses. And we see these in a lot of our diseases. And I've just named them there in some form of categorization. But that doesn't tell us really much about the molecular or cellular mechanisms when we understand our patients. So we can either look at uveitis or continue to look at it as one umbrella disease where we're looking at common effector mechanisms to drive effective translation and looking for drugs that may be effective for a large population of patients. And to date, I would argue polemically that that has failed. Or we can look at them as many clinical disorders, and that possibly is true, where the clinical descriptors are there, but they often overlap. So that doesn't hold in my mind. And we need to go to a modern taxonomy, which we're doing, which is looking at really a cellular and molecular phenotype associated with genetic background, which defines really therefore a whole raft of what we may then determine as personalized rare disorders, irrespective of their phenotype. And of course, that's the sort of drive I'm pushing towards at the moment. Why? Well, certainly if we look at some of the historical data, which I'd like to share, classically you treat these patients with high-dose steroids if they got sight-threatening disease, and frightening morbidity and overuse. So we then use immunomodulators, and over time, certain calcineurin inhibitors that NFAT inhibitors such as cyclosporin or tacrolimus have been used. And if we look at those, we can see we get some response. There is an ability to reduce the steroid loading, but patients still require a morbid amount of steroids at 10 milligrams. And very few patients, and it takes an awful long time to be able to wean off the steroids whilst we're trying to control disease. And the same can be said for purine analog, slightly probably better because its tolerance is better in patients, and that's mycophenolate mofetil or Cellcept as we were using it under patent then. And you almost get a replica picture of response where still a lot of patients are requiring a morbid amount of prednisolone a day in order to control their inflammation. So I put out there as a headline, potentially or not potentially, is unsatisfactory. So if we look, it's not just us. The Americans, as you've done, have done a brilliant job in being able to create large cohorts, able to show exactly the same for lots of different drugs. I'm not going to go through each one because it's not worth it, because essentially you struggle to get a 60% response as defined by controlling inflammation and reducing steroid loading below 10 milligrams a day. And I keep emphasizing that because if you look at the population data or morbidity on patients on 10 milligrams a day, it is high. You still are increasing the cardiovascular risk. You're engaging patients in osteoporosis. You're increasing the likelihood of steroid-induced diabetes, as well as the psychological and habitus side effects of taking steroids. So there is a need to move on. And very early recognizing that need, using the animal model, we were sort of looking at what generates tissue damage within the retina during experimental autoimmune uveitic retinitis. Now, this is a traditional autoimmune model in the rat or the mouse. And essentially, this is induced by retinal antigen with an adjuvant to induce the innate immune system, such as Freund's adjuvant. So a little bit of mix-up with TB protein. And you induce an inflammation that has a peak and then goes into a resolution period where there is persistent inflammation. But during the peak, we noticed in the rat model very early on, or I did in the early days, that it was indeed the macrophages, as seen in the ED1 positive macrophages, that were generating nitric oxide and nitrotyrosine, so nitrosylating the cell membranes and creating macrophage activation and damage to the tissue. So as a result of recognizing this was TNF dependent, we sort of generated an ability to create a fusion protein, which we did at that time with one of the receptors of TNF-P55 or receptor 1, and noticed that it could attenuate the disease in the rat model and attenuate certainly the macrophage nitrite production as a sort of readout of inhibition of the innate immune response. But also it suppressed the disease, it suppressed the target organ damage, it suppressed T cell responses whilst downregulating the macrophage response. And we sort of continued, I'm not going to spend long on this, continued doing this to show how it was receptor 1 dependent of the TNF pathway by using various knockout mice of the receptors for TNF. And as you can see, it attenuates the acute disease in the mouse model as well. And others have shown this as well, including Rachel Caspi's group at the NEI. So in essence, what we knew was that, as others have shown, is that the Th1 response, the gamma response, is very dependent on TNF to drive the macrophage activation and the nitrite response and the upregulation for antigen presentation in the macrophages to promulgate the immune response in the tissue. So it seemed very logical that this in the animal model was therefore translatable into a therapy for patients with uveitis. So we utilized alongside Herman Waldman creating a fusion protein that we generated in patients and did one of the earlier phase 1, phase 2 studies in this uveitis using this fusion protein to try and see if we could attenuate uveitis. And indeed, we did in patients with active disease of many different types of uveitis. And indeed, we were able to get a clinical response in the patients, but they still required a significant amount of steroids. Now, at the same time, interest was gained, or not at the same time, but later on, sadly a decade later, industry got involved. And of course, there was this multinational trial run by AbbVie for anti-TNFs. This time they just used a neutralizing antibody to inhibit the TNF response in a blanket uveitis cohort of patients. They did a very good trial design, or we did a very good trial design, where it was really an experiment to show time to treatment failure if you randomized to placebo or adalimumab, and were able, when you just rapidly withdrew the steroids, did you get a TNF protective effect? And the answer to that is yes, you did. The odds ratios, hazard ratios, sorry, were very good at 50% for this, but patients still failed on this treatment, and there's significant adverse events. Now, this has been licensed for use and it's very welcome, but indeed, still we recognize that it is difficult to get more than a 70% response rate if you just treat all uveitis as the same. So we then looked and said, well, maybe if we just took a single clinical entity, and there is a condition in children called juvenile idiopathic arthritis. It's a chronic inflammatory disease of the joints, of which about 15 to 30% of patients, depending on where you are around the world, will get uveitis, of which a significant proportion, it will be persistent, chronic, and lead to tissue damage and loss of vision. So in this, we know that patients who require, who have JIA uveitis do require escalation to quite significant immunomodulation. And historically, the outcomes of these patients was poor if you didn't treat aggressively. So we did a similar thing, which was called the Sycamore study, funded simply through charity and also through the government, through the NIHR in Britain. And we randomized patients 2-to-1 in this disease, so a single entity phenotype of disease, and to look at the outcomes, very similar to the visual trials. So we took patients that were already aggressive. They had to be on stable systemic methotrexate dose and on 2 or more drops a day to try and treat their uveitis were still active. And when we looked at the outcome measures, this trial was stopped early because of the profound effect of adalimumab in this cohort study of the randomized controlled trial. And that's because very early on, it was noticed that there was a very significant response with a good hazard ratio on the analysis of the primary outcome of time to treatment failure. So the trial was stopped in order to license the drug for use in patients with JIA uveitis. But despite that, 30% of patients remain refractory to treatment. So again, without much evidence, we do the normal sort of clinical thing, which is go on to another study and say, well, we also noticed from these children, they have high IL-6 levels. So why don't we try and just inhibit with tocilizumab in what we called an aptitude trial, which was essentially looking at tocilizumab in anti-TNF refractory patients, and did it in an adaptive design study with a Bayesian statistics to look at whether we would get a response that would give us an indication whether we should use this or go forward to a fuller randomized controlled trial, phase 3 trial. And I'm not asking you to look through this. I just want to sort of simply say that 21 patients the Bayesian design was we were going to enroll 22 patients. The statistics showed we had to show a 50% response, but indeed what we showed by essentially is we had a lot of discontinuation because of lack of effect. And really at the end of the day, the primary endpoint was not met. That's the important thing. But we did notice still that, and it's very dangerous on small numbers, that the patients that did respond seemed to have a specific phenotype, particularly a vascular leakage. So again, it tells us that the cellular molecular mechanisms are unknown, and we really need to push down into a cellular and molecular phenotype to understand how best to target if we're going down the lines of anti-cytokine mediated treatments, the right patient at the right time. And to do this, we set up through the MRC a program grant that was funded, which is called Cluster. It involves Bristol, UCL, Manchester and Cambridge universities in order to have a stratified medicine approach to basically bring together the clinical phenotype, the genetic and molecular aspects of the patients and their therapeutic responses from the trials, because at the same time we collected tissue, as in aqueous, collected blood, and therefore we had the RNA, DNA, and peripheral blood leukocytes to investigate. Now, this is the group called the Cluster Consortium, which is full of the data scientists, the clinicians, and the basic scientists together. And COVID has completely scuppered it. So I have no data except for to excitingly say that what we've done is collected all the data. All the analysis has been put in the open access Transmart system in order to really look at all the biomarkers through RNA-seq, through the clinical outcome data, through the flow cytometry analysis of the peripheral blood leukocytes and the cytokine responses, in order to assess if we can predict a stratified response of why some patients responded and others didn't. And this includes both uveitis, but also a whole cohort of patients with just JIA, meaning just arthritis with no uveitis. And the idea here is to start generating a taxonomy of molecular and cellular phenotype for our patients with this devastating inflammatory disease. And within this, of course, we're applying machine learning to see if that will facilitate us in when we are able to look at cellular and molecular phenotypes. So moving forward, the big question to me is, using the Harvard model, is how do we become more precise, predictive, and personalized? And part of that is generating, as we know, the biomarkers, either for diagnosis, prognosis, treatment, but also remission. One of the big questions that comes to mind is, when do we stop treatment? How do we know we've truly modulated disease outcome that we can satisfactorily stop treatment? A true disease remission. Now, to get there, we've tried various angles. The first I'm going to take you through is work really started very early on with Richard Lee during his PhD. And he's taken this on further obviously as an independent researcher himself now in collaboration. So steroid resistance, one thing we noticed is, why do some patients who not only are refractory to biologics, but they're always refractory to steroids, they require enormous high dose steroids in order to get control of the disease? And one of the things here is that it's not uveitis specific. This is very also seen across disease states, whether that's in renal, idiopathic thrombocytopenic purpura, inflammatory bowel disease, asthma. It's a very common scenario where about 30% of patients require phenomenal doses of steroids in order to get control of their disease. So early on, Richard, during his PhD, generated understanding that we found from patients that there was a subset of T cells that were refractory to treatment with glucocorticoids. And I'll go in a little bit more detail of that in a second. And furthermore, that we could predict potentially who those patients would be. So that would help us personalize treatment of knowing who would require escalation of therapy early, because they require so much steroid use. And to do that, it was very simple. We just simply looked at T cell proliferation in subsets of T cells or in whole T cell populations using a straightforward, initially CFFC dilutional assay. And we knew that in the presence of dexamethasone in vitro, you can either be sensitive and you're inhibiting all the proliferation, or T cells continue to proliferate and generate cytokine, and we call those resistant. And that was a very well-defined response that we could classify in our patients according to whether they were steroid resistant, needing more than 10 milligrams a day, or to remain in remission, or steroid sensitive, in that we were quickly able to get into remission in these patients and they required lower doses. A very crude comparator, but something we could put a handle on in order to mask the investigation very early on. And indeed, when we did that, quite surprisingly, with incredibly small numbers, there was a very good positive predictive value, although the negative predictive value was much lower. It gave us an indication that we may have a diagnostic companion biomarker to a therapy we might be able to introduce to overcome steroid resistance. So in order to overcome steroid resistance, early on, we were looking at essentially how do we define the biomarker? And this is just to quickly show what Richard did very early on in his PhD, which was to show that essentially it was an intermediate population of a CD4 compartment that expressed interleukin-2 receptor that remained resistant to dexamethasone compared to the negative compartment. So it's taking that population of steroids that we were able, of T cells, that were able to elucidate the fact that it was these cells that were very high secretors of interleukin-17. And they expressed, as we know, a chemokine receptor CCR6. So could we utilize that for therapeutic gain? And the idea here is to say, well, one of the things the late Bob Nussenblatt showed back in the early 80s was that you could actually almost treat any uveitis if you use cyclosporin. Sadly, it required a phenomenal dose of 10 to 15 milligrams per kilogram, which nearly pushes every patient into renal failure eventually. So it's not really very tractable long term, but it overcame the patients who are most aggressive. And in fact, when you look back, were the ones that were likely to be steroid refractory. So we did the experiments where we said, well, do calcineurin inhibitors overcome steroid resistance in these subsets of Th17 cells? That was published by Richard's group later on in PNAS. And what he showed was indeed you can. It's the cyclosporin that really is very sensitive to inhibiting Th17 cells in their suppression for proliferation. And we did this in various models, be it an OT2 or ovalbumin transgenic model or a HEL transgenic model. You got the same expression where you were able to inhibit, that's percentage suppression, with cyclosporin of Th17 replication. And it equally inhibits EAU, which is what the bottom graphs are showing. So it, as we would expect with cyclosporin. When we looked at it in more detail, we can see that it also inhibits the frequency of the IL-17 positive cells. So it's not just looking at the Th17 phenotype, but what they produce, and the concomitant PCRs would show that you are inhibiting the Th17 lineage. So this looked very attractive for translation through. And when we did further analysis, we could see that really when you're looking at Th17 cells in the face of steroids, they really were not restricted, and they had a wide genome spread of lack of suppression of canonical genes that express to drive an IL-17 response through IL-17, 22 and 23. So moving on, we looked at the concept of treating inflammatory diseases with the concept of steroid resistance and being able to target with a companion biomarker to assess who might be steroid resistant by doing an antibody drug conjugate, and using the fact that these cells are CCR6 positive, and the CCR6 gets internalized into the lysosomal system, as we can see here. So we know that all we needed to do, sounds very simple, is conjugate a calcineurin inhibitor such as cyclosporin. Long story short, that didn't work. Or tacrolimus, which is another one we could use in order to generate an adequate antibody drug conjugate. So where we are at the moment is working to generate that, having generated that antibody, that it will bind obviously as an antibody drug conjugate using the CCR6 into the cell, essentially gets internalized, it's lysed through the pH system of the lysosome through its linker, and then you have a free drug that binds to the target of the cells you want to inhibit, the Th17 positive cells, reducing the requirement of the high loads of the calcineurin inhibitors, which prevent its real wholesale use because of the side effects they produce when you just give orally to patients. So we're doing this in concert with obviously many collaborators now in order to generate, moving forward to testing the antibody drug conjugate in man over the coming year or two. Now it's been further delayed. I keep using the excuse of COVID, but I'll continue to do that over this past year. So that's one angle, a companion biomarker which you can detect responses that you may be able to generate a specific drug response to, such as through an antibody drug conjugate, through to more molecular and cellular mechanisms by looking at specific diseases. And the next bit of the story I'd like to sort of discuss is the spondyloarthropathies. So spondyloarthropathy is a systemic disease which can be either seronegative or seropositive, which means patients are HLA-B27 positive, an MHC class 1 restricted disease. It can give rise to many different diseases, classically spondyloarthropathy being the spine and peripheral joints, but also related to inflammatory bowel disease. And as we know in uveitis, as we know in ophthalmology, specifically uveitis with or without the systemic features of disease. And it's very early on that I had the pleasure of chairing a trainee meeting at the Academy of Medical Sciences in London when I used to be chair of the training committee. And a young person, Jonathan Sherlock, who was currently then at DNAX, was working with Dan Quire on basically looking at and presenting this paper back in 2012, where he described IL-23 inducing spondyloarthropathy by acting on specific cells that were resident in the enthesis of the joints, and therefore ascribed really that the reason that patients got what's called enthesitis and then spondylitis was because of the fact they had these resident cells that were able to respond to IL-23. So really, a lot of these diseases are IL-23 driven. So taking it to the eye, there's two things here which I'm very happily get shot down for. The first is to describe whether this novel T cell population exists in the eye. And if so, what the heck do we mean by an enthesis in the eye, the tendon of the eye? Well, as we know, extraocular muscles that move the eye are present, and they will actually have tendons and fibers that go through into the sclera and actually get through into almost the ciliary body and the not quite the trabecular meshwork, but in that area of the eye. So rightly or wrongly, calling that the extraocular muscle scleral enthesis, we actually see a CD3 positive population in basically normal human eyes. So the argument is one describing an enthesis, which is aligned to essentially, as we can see here, CD3 cells crossing through the extraocular muscle as it starts to enter into the eye. If we look in more detail, they're aligned to podoplanin, which of course is the matrix you require within the enthesis and connective tissue. So it's very, very similar to that, but you see in the joint and in the spine. But most interestingly, whilst very sparse in the healthy, they obviously, and maybe not unexpectedly, in a uveitic eye, they increase in the number of T cells. What we don't know is whether these T cells are the specific IL-23 receptor positive, CD3 positive cells that have been described in the enthesis. So to do that, we're trying to do that through human biopsies, which we've been doing. And we sort of using FACS sorting, isolating them out from looking at different forms of iris to scleral punches and trying to look to see if we can see T cells. Well, at the moment, you know, it's very small numbers. And indeed, what we're seeing is increased T cell compartment of CD3 cells within the entheses of the eye within uveitis. It's of no surprise, frankly. If we go to the mouse model to try and really hone down how we find the CD3 positive 4 and 8 negative cells, we also find them in the eye, very similar anatomically to the human, in the BLAC6 wild type mouse. So if we take that forward and say, well, okay, if they're there and you squirt in some IL-23, then do you get inflammation? So we decided to do this through a system that's been utilized before and use an AAV capsid through SSH10 and have a hyperkine vector of IL-23. So when it's transduced, it will basically secrete IL-23. And does it therefore help does it deliver uveitis? And indeed it does. So when we inject versus the GFP control, we're seeing that we get increased cells, just generally looking at 45 marker here, we get increased cells within the eye. And we also get an increased number of the CD3 double negative cells. Now, we don't know where these are at the moment because we just took the tissue out and isolated them by flow. And here's some examples of the vector giving you disease during day 10 following the vector delivery. And we also did it in the RAG knockout to show that there is a dependency, obviously, on having an active immune system to get disease. As you can see, the RAG knockouts didn't really generate increased numbers of cells. You wouldn't expect them to. But certainly when you give the hyperkine, you're seeing quite pronounced inflammation and an increased number of these cells within the tissue. So why worry about that? Well, I think the answer here is looking again at noticing in certain disease phenotypes, if we're then able to acknowledge that these are IL-23 responsive diseases, we may be able to look at delivering therapies locally that would inhibit the IL-23 response to prevent the recurrent uveitis patients get with anterior uveitis, particularly associated with spondyloarthropathies, a very significant burden on the healthcare system. So that was another angle of the story going through. And again, taking forward as to whether we can look at more angles of it, we really I want to take you through a little bit of a story of one angle about how do we humanize our basic science platform to be able to create better biomarkers, but also molecular targets for treating inflammation. And doing this using essentially the mouse model system, obviously to start with, but trying to make it much more translatable so that we can get it into man quicker. And I'd like to take some examples. One of the aspects that we get to increasingly understand and have underestimated, or I certainly have underestimated in the past, is the assessment that tissue has on impacting on the liberation and the regulation of both infectious and immune-mediated inflammatory diseases. And we also know that there are various checkpoints that regulate immune responses. And I just wanted to highlight two things. The first is work by Jan Liu here, who's a postdoc in the labs of mine, who's really been working at understanding the role of IRAK-M. IRAK-M is interferon receptor associated kinase, and M, which is actually one of its forms, is a negative regulator of the TLR or an IL-1 pathway intracellularly, so it prevents activation, particularly of NF-kappa B. It internally regulates the cell response. And one of the aspects which was, when it was first described, was thought to be restricted just to monocyte lineage and macrophage lineage, including microglia. But actually it's also very well expressed, as we've shown, by RPE. So we wanted to look, first of all, whether it's expressed, which we did, and then look at saying, well, what happens in the knockout mouse when you do various diseases? And to show when you lose internal regulation, so this is about how does the tissue regulate immune responses. The first was just using a light model. We saw in the knockout mouse of the IRAK-M just huge increased numbers in of the monocyte macrophage lineage, looking at just simply CD11b in this preliminary data. And equally, you got massively worse experimental autoimmune uveitis, as shown in this OCT of disease at day 21 compared to a wild type. And when you saw this in the knockout, it's really all down to the dysregulation of the innate immune system. It doesn't tell us what's happening to the tissue, but it begs the question of how much does the tissue control control inflammatory responses, and whether we should also be targeting by either understanding the tissue more of why some patients have a worse prognosis to others with the same disease. So to do this with IRAK-M, we were very interested by looking at both at microglia and also RPE as to what happens with the IRAK-M expression over time in just a very acute immune response induced by endotoxin. And you'd expect through that TLR4 response that IRAK-M would be pivotal to controlling the regulation. And indeed, as you inject the endotoxin, you measure the IRAK-M levels of the microglia go up, and then they go down again back to normal levels as the EIU becomes resolved. When you look at human donors, which we did, and mine the data for AMD, you can see IRAK-M expression is downregulated in AMD, an immune response that prevents the regulation of inflammatory responses within the RPE during a degenerative process. And that again is also seen in our preliminary data in the mouse. Now, this is all very unpublished preliminary data, so take it as you wish. But when we look at some of the early data we've just done looking at human RPE and choroid, with age, along with the retina, you get a downregulation both of IRAK-M in the choroid RPE and in the retina. So everything sort of highlights how the loss of tissue control, either with age or sometimes by donor, might be very important in regulating inflammatory responses as we go forward. So the other way of doing this, and I can see Danny's online, so I'm feeling very humble presenting this in the face of Danny. But if you look at reporter mice that use Cree systems and therefore can look at tissue responses of cell subtypes, and for this example, we're taking microglia, of course, you can get into looking at specific RNA and cellular and molecular responses of microglia during various forms of inflammation, as has been done by many now, both in the brain and in the eye. And we've done this ourselves using a Cree-Rosa system for microglial tagging. It is still got some leak, but it's relatively specific for microglia. And we looked at a way of inducing with tamoxifen, and we do this now topically rather than subcutaneously, because we get an equally efficacious response in this model system to allow us to just feel that 98% of the time we're only expressing in microglia. And as a result, we're able to, first of all, do two things. We're able to look, as everyone is looking at, is what is the tissue response and how does it become dysregulated during inflammation? And when we do this in the mouse model system with experimental induced, endotoxin-induced uveitis, so again, the TLR4 system, we can see that very early on, we get upregulation of certain genes, which is what you'd expect, and downregulation of particularly some of the regulatory genes as a result of stimulating with endotoxin in the microglial population. Importantly, by 2 weeks, it returns to normal. So the reason we chose EIU was because we know clinically in this model system, everything goes back to normal after about 2 weeks. But even if you therefore just insult this tissue, it's able to regulate itself quite well and get back to normal within 2 weeks, which is probably different than we see in autoimmune responses, such as in EAU, when we're looking at the response again in the same system by analyzing the microglial responses using the tagged system. If we try and do this early on, which we did, and I haven't got data to share of the ROSA data on the tag system. If we did the very leaky CX3CR1 to try and look at microglial responses, and it's not solely microglial in this model now, because we know it's expressed on many other cells, we can see very distinct changes that don't ever recover in patients in mice with EAU. And that's an important point, which is in chronic persistent antigen-driven disease, there remains a persistent dysregulation of response that we observed. I'd like to sort of, beg your pardon, go back and say what we did notice in that, for an ability to do so, was to extract the T cells in a model where we induce the disease and then treated with a half dose of TNF to see if we could get any breakthrough so they had persistent disease. And we saw various cytokines that remained upregulated in those mice that were not responding to TNF inhibition. And that's what I've highlighted here by the data that we did through the RNA-seq, which was to show that some mice described the fact that we may be able to target, if you were able to do this in man, against IL-6 or against IL-17 by various monoclonals. They were the two real highlights that came out in TNF refractory disease in the mouse system. So moving along to how we might be able to have the biomarker, this is the more tricky aspect of how we how we are able to translate through. And again, if we look at a system of an adaptive transfer system to try and understand the disease in the mouse more before we then get into human, we've sort of generated an adaptive transfer model using a CAG GFP mouse, where we're basically generating antigen-specific T cells. We're purifying the T cells, having green cells going into a red microglial mouse. So we're able to take away both the microglial tissue compartment versus the infiltrative compartment to understand the two aspects of tissue regulation versus inflammatory response of the invading cells within the tissue. And we're able to do this quite nicely. These are pictures just to show how we can demonstrate the T cells that are infiltrating in the eye in this flat mount. sorry, in this picture, it's not a flat mount, it's a live in vivo picture, along with the red, which are the microglia. Again, showing in more detail the CD4 T cells. I don't know if it's meant to show them moving, but this next one will hopefully show it more. Now, this is in a chronic phase of disease, and these are the CD4 T cells within the eye. And the reason I sort of hesitate and stop there and going to play it again is that at this stage, clinically, we would say that the disease is in resolution or in long-term remission. And in a patient, we would argue that they looked inactive. But when you, again, just showing this, show the CD4 T cells, there's many of them still in the tissue, something we cannot see clinically. So we don't have a biomarker to know whether the disease has gone into complete remission. And therefore, to do so, we're doing the experiments to see how we can help the smarter people around, which has been generated by Jesse in Rochester, along with Colin, who went out there. We got funding to send out there. And this is in the mouse modeling system, essentially, of an inflamed various images of inflamed mouse systems using AO, SLO. And what we can see, obviously, is massive amounts of different inflammatory cells. Of course, what we're doing now is adapting machine learning so that without tagging in the future, we'll be able to try and discern what type of cells these are. But as it's looping back and forth, I just want to demonstrate that you can see almost the adherence and rolling and extravasation and migration of cells into the tissue. I hope you would agree, it's quite an enjoyable picture to see that you'll be able to replicate this easier in man going forward as a biomarker to know how these cells are acting and what happens during the course of disease and during treatment as a biomarker. So we're utilizing the animal model with tag systems to inform the machine learning with the aspects that we'd look at here to try and define what cells are what, whether they're T cells or macrophages going forward. But the whole concept really, for me, to treat immune-mediated inflammatory disorders, which include uveitis, is to really be able to understand the preclinical phase more in order to be precise and predictive through biomarkers, understanding of molecular and cellular signatures to essentially target treatments much quicker and earlier to prevent the devastation of disease we see. I don't think we'll ever be there to understand the true genetic risk and complexity in immune diseases because there's a multitude of genes, but they will assist and cluster will help understand which patients are truly at risk and prognosticate disease and how they may respond to treatments going forward. And that will give an example in one disease state as to whether we can extrapolate going forward. So my hope I've put 25 years because I'm feeling pessimistic, is that we'll gain more patient stratification to target therapy. I think that will happen quicker than I think, and we'll certainly be able to elaborate out immune imaging as a biomarker to know what tissue response and also what treatment response, and hopefully whether we have a disease response to know whether we're in remission to target treatments better. But most importantly, after treating patients for now 35 years, I hope we can get to having a completely steroid-free life for these patients to give them better outcomes in the longer term. Thank you very much for listening.
Thank you very much. The question, please, if you have, send me by chat and we will start populating that as we go.
I'm working out how to stop sharing here, sorry.
Andrew, this is Tony Nesburn. I am interested to know, in humans with uveitis, are you using anterior-chamber tap cells to figure out what's going on in the eye, or what cell system are you looking at?
Yeah, so that's a great question. So we do use anterior chamber cells. The caveat to that is they're not in the tissue. We obviously can't biopsy the tissue for the retina or the choroid. We do get some tissue during uveitis from trabeculectomies where you might get some iris. We do get some vitreous at times, but really during the course of disease, it's about taking the solution side, taking the aqueous. Now that might not be an adequate representation of what actually is happening in the tissue. And that remains why we need better imaging techniques through Jesse and the likes in order to be able to know what's going on in the tissue. But we won't be able to delineate molecular or cellular signatures because we just can't get the cells like you can from the joint, the synovium, the lung, or the liver, or cancer. So that will hold us back.
All right, let's move to Maciej.
Hello, Andrew. Excellent talk. Thank you very much for this talk. So I have a naive question actually about the impact of uveitis on choriocapillaris and choroid. Because as far as I know, there is this effect of leaking of fluorescence visible in uveitis case. So would it be possible to think about the biomarker in choriocapillaris, for example, to look at how they are, how they leak, how they are prone to leaking or something like this?
No, it's a great question. So in man, where we've moved to is basically away from using indocyanine green, which would sort of look at the choroid in a bit more detail. The difficulty with that, it's hard to delineate what is damage and activity with ICG. So I'm going to come back, and I didn't show the data because I looked at it and I was very uncomfortable with that's not my screen. I was very uncomfortable to show it. We have just set up a model in the albino mouse. And the reason for doing that is to be able to look at the choroid and choriocapillaris and the mouse modeling systems of inflammation. So with the albino, obviously you don't have the pigmentation in the RPE. We should be able to get straight through, and then we'll be able to image it, but also it'll be easier on light sheets. So we'll be able to take out the eye, create a light sheet of the whole of the retinal choroid system, and look at different phases as to what's happening with the vasculature and also the infiltration. I can't answer your question, but you're absolutely right to ask. And that is a whole group of work we're doing, but the data is so preliminary, it was not right to show it.
Andrew, indeed, this was a wonderful presentation, but I even have a better news for you. Eric just woke up and he's ready to ask you a question. And unfortunately, he's going to be in Scottish.
It will be in Scottish, Andrew. Sorry. Good to see you.
Likewise.
And really interesting talk. Really nice work. A couple of things on the IL-17 story and the T cells. Did you look, I mean, even in this last set, did you try, say, using you did the adoptive transfer studies, you can also use IL-17 reporter. Cells from IL-17 reporter mice, did you?
Yes, no, we haven't done that, but we, it's the usual answer to the question. We are going to do that for that very reason. I think you're getting to. The other thing I didn't bring out, knowing that your face is beautifully there, is of course that we get neutrophils in this system, and no question they are IL-17 producing in there during the acute phase of the uveitic response.
Very interesting.
So we do. So yeah. So we do need to know, and you do see a lot of neutrophils in biopsies of man as well.
Right. That's what I was going to ask. What do you think the IL-17 is actually doing? Because a major role is to recruit.
Yeah.
Directly to recruit.
Correct.
neutrophils.
Yeah. Absolutely. So the really interesting thing is people underestimate I think people underestimate the fact that I think the IL-17 production is to recruit, and I think the recruitment is mainly of neutrophils, and in chronic phases you get a very SLE looking picture in the pathology. So you get these neutrophil rafts and things, and it's quite interesting, but it's underestimated pathologically. So it's about bringing that understanding in. So I don't know the answer because we haven't done the experiments.
Okay, great.
Okay, thank you. Let's move on to Philip.
Hi, Dr. Dick, Philip Kaiser. Really nice talk. I enjoyed it a lot. I kind of was intrigued by the point you made about cyclosporin being effective, but yet not really feasible to use because of the renal side effects. And you also have the same problem with side effects in the long term with prednisone. And all of this got me thinking about, multi-drug approaches, polypharmacology, systems pharmacology. And I was just curious from a clinical perspective, or your clinical experience, do you have patients who are on some, below 10 milligram prednisone dose plus Humira plus some low dose of cyclosporin? And if so, how do those patients do?
Yeah, no, thank you for asking. So the answer to that is yes. It's hard to predict which patients will get to it, but yes, you do get patients, and certainly I have a lot of patients that are on less than 7 milligrams of prednisolone, which is probably a non-morbid amount of steroid. I don't use cyclosporin at all because I think it's a side effect profile, particularly cardiovascular risk at any dose is actually unacceptable. So they are generally either on Cellcept or mycophenolate mofetil or methotrexate. The reason I'm not using tacrolimus also is because actually, whilst I think it's a very, very good drug, the patients don't tolerate the other side effects like tremor and headache they get with it. So you actually get a very fine tremor with tacrolimus. Which is disinhibiting to quite a lot of people. So I think what we're getting to is would you ever encourage polypharmacy? And the answer to that is undoubtedly what in the shorter term is going to be yes. In the longer term, if you're more diagnostic biomarker, you should get more precise and you probably won't need it. The reasons that often methotrexate or a purine analog such as mycophenolate mofetil work is whilst you're using a biologic, it's just inhibiting the ADAs. So you're not just getting an added immunosuppressive or immunomodulatory effect, you're also probably increasing the efficacy of the biologic. And there's good data out there that that's the case. ADAs are anti-drug antibodies are underestimated problem for biologics.
Right. Thank you.
All right, let's move to Danny.
Hey, Andrew. Great talk. I really liked your few early slides, especially the one where you show how these diseases could be organ specific, systemic. I really liked that. I thought it was very illuminating, and I also really appreciated what the previous question, essentially that there's essentially how far can you push the steroids. And at some point, yes, it is treatable, but you can't have the patient risk any other potential morbidities. And as a PhD-minded person, I don't think about those problems as much. So I appreciate that. The question I have is the point you brought up about remission, which is a really interesting one that I was made aware of talking back, this is maybe 6 or 7 years ago, to Glenn Jaffe, and he had mentioned the same thing, is how do we know our patients are in remission or they're just temporarily being quiet, the eye is quiet because there's a waxing and waning effect to the inflammatory process like other autoimmune diseases? Or is it possible that the autoimmune disease just simply, burnt out? So you see an example of that in allergy with kids, that eventually the allergy just burns out. So one of the things I proposed at the time, and I'm wondering if anybody has tried this, clearly we don't have imaging modalities right now that will tell us, and that's what you're working on, obviously, that will tell us in the eye, in situ, whether there's T cells and are they activating, etc. We don't have access to the lymph nodes. We're not going to start resecting lymph nodes where the T cells are, and but what we do have a lot of access to, and almost infinite amount to some extent, is the blood. right? And we can get T cells from the blood, and you can get it quite regularly from the patient. No simple thing, but it's not difficult. And you had shown how you could do in vitro assays, for example, to start characterizing patients, whether they'd be refractory or not. Why not do these in vitro assays on patients which either have a quiet eye or not, and profile those T cells really well systemically to begin to get clues about what does remission potentially look at in those T cells, those circulating T cells, which you know have either come from the lymph node or had come from the bone marrow or circulating from lymph node to lymph node, etc. What do you think about that as a possibility? Has it been done? If can it be done?
Last question, answer first. Yes, it can be done. There's no question. Two is, I think in order to do so, as you know, the Pasteur has generated a lot of good data on trying to look at normal human responses in thousands of patients using their, what's it called? Anyway, they've got a system where they can get the blood and they can look at the PBLs, sort them out. And it's quite smart. Okay, it's got true sort or something like that. But anyway,
published at ARVO. They presented it at ARVO 1
Yeah,
year.
yeah. So it's Dara Duffy's sort of working consortium. Yeah. So if you look at that, which they've done, and then what COVID has taught us about looking at massive thousands of patients, a population with a disease, it's a real shame they didn't also look at a normal population at the same time, because I think that would have been very useful. So I'm going a long way around to say yes, but I think you need lots of patients to do it, because there's going to be a diversity in response in human beings before you see a signature. So the other way round, whilst I think you should do that and it should continue as huge cohort studies, so we just become nested as one disease amongst many in a population-based study. That's what I would love to see. The other way of doing it is like we're doing with clusters, take one disease and just see what the response has been to therapies which are beautifully defined by the trials. And then out of that, we're hoping to see exactly what you've asked. And then we'll be able to use that data on a bigger population size to try and get to the answer quicker.
So, and I just wanted to just say, we have now a 36 color panel for flow cytometry and spectral analysis, which we used and we sort of rolled out during COVID. Before COVID, but quickly for processing and analyzing in a very unbiased, bioinformatic data driven way. So if we can ever be of help in doing that sort of thing on patient samples from the blood, please let me know.
Well, that would be great.
We're already starting to apply that to vitreous samples and aqueous humor samples and tear. And I don't, I think it'd be better if we, if we had had open lines of communication.
Yeah, that'd be great. No, I agree. We should do that because we have a measly 16 color. So thank you for emphasizing our inadequacy there. No, but well done getting that panel. Brilliant. Yeah, really useful. Thank you.
Just wanted to remind you that we're going to meet in the same place in the same time a week from now, and Gordon Fain is going to talk about electrophysiological approaches to understand retina function. You're all invited, your neighbors, your family, and your enemies. So all of them are welcome here. And the final news is that Dr. Brown is not out of town, so he's going to give a final word.
Yeah, thank you very much. That was a really fascinating talk. I'm a clinician and want to be scientist as well. And so I have a good number of patients with uveitis. And in your talk, the thing that kind of, well, when I think about all of my patients, I think about activity of disease. And so when you talk about these IL-17 positive patients that are refractory unless they have cyclosporin treatment, is there not an approach where you could use cyclosporin for a very limited period of time? I know it takes about 3 to 6 months to get true effect, but say, you say this is going to be the phase where I use cyclosporin, get them off of it, but make sure that the upstream regulators of that immune response never become active again. with other agents?
So I think so the answer to that, I come back to the fact that you'll take a long time to convince me to use cyclosporin again. Within a 3-month period, your cardiovascular risk has already increased because your lipid profile is dysregulated, and you've already got. I did all this work back in the early 90s, and you get massive tubular dysfunction within 6 weeks. So you're already got kidney influence, even at the doses you're using. So you'll never convince me to do that in those patients, even though
on January 6th, the
So I think if you said, well, could you do that with tacrolimus? That might be more possible. But again, you know, it's about, I'm trying to get away from saying, let's take all the patients and treat them as the same, to moving into stratification. So if I knew that patient was more steroid refractory and had those subtypes of cells, then that might be able to target that population, as opposed to blanketly targeting everyone. Because again, what we'll find personally is that we'll find a drug that works, it will be useful, but it will only work in about 60% of patients. It would be my prediction. Sorry to be so pessimistic.
No, totally reasonable. Cyclosporin is a toxin. Thank you.
Andrew,
Yeah.
thank you again. Thank you everybody for attending, and until next week.
Thank you, everybody. Thank you.
Great to see you, Andrew. Send me some fish and chips.
Oh, yeah, will do. Look after yourself, Steve.
All right. You will, my friend.
Bye, everybody.
Well, don't send
thank you
it.
likewise.
Steve is on diet. He needs to be a slimmer.
Ha!
It's
Ciao.
looking good.
I don't know. Depends who says that.
All right, I'm going to love and leave you all. Take care.
Bye-bye.
Thank you.
bye-bye. Thank you.